on Dr. Phil Rosenfeld, Professor of Ophthalmology at the Bascom Palmer Eye Institute, where I'm also the course co-director of the annual Angiogenesis, Exudation, and Degeneration meeting. New Retina Radio invited Dr. John Kitchens to moderate discussions from speakers who presented at this year's Angiogenesis meeting. This is episode 1 of 3, so be sure to stay tuned for future episodes. In this installment, Dr. Kitchens hears from Drs. Pravin Dugel and Vas Sadda, who summarized their presentations about the effects of complement inhibition in patients with nascent geographic atrophy and complete geographic atrophy. After the break, the panel discusses the future of retina practices as it relates to therapies for geographic atrophy.
I'm John Kitchens, and I'm joined today by Pravin Dugel and Vas Sadda. Pravin is Executive VP and Chief Business and Strategy Officer at Iveric Bio and a clinical professor of ophthalmology at the Keck School of Medicine. How are you, Pravin?
John, thank you. I'm honored to be here. Thank you for inviting me. I'm doing extremely well. Thank you.
Fantastic. And we also have Vas Sadda, who is a professor of ophthalmology at UCLA and the Doheny Eye Institute. Vas, thanks for joining us.
Hey, John, it's great to be here with you and Pravin. Looking forward to our discussion.
So we are going to review both of your presentations from this year's angiogenesis. And as most of us would expect from an angiogenesis meeting, we're going to talk about geographic atrophy. But actually, that's a really pressing issue now because it's one of the few conditions that we have that just simply is untreatable, and it may not remain that way for long. So let's dive in. Pravin, your presentation was titled C5 inhibition of avacincaptad, or ACP as I will call it from now forward, for the treatment of geographic atrophy. Tell me a little bit about that talk.
Yeah, so John, it is a hard name to pronounce, so we'll call it ACP, but Zimura is what people know it better as. So it is indeed a small molecule that is a C5 inhibitor. And what we have is we're the first positive phase 3 study and the first time that we've seen a treatment of geographic atrophy that is continuous for 18 months. Now, it's important to remember that the patients that we treated were patients with extrafoveal geographic atrophy. So the reason that that's important to remember is that this is the fastest growing geographic atrophy that we know of. And what we're able to show, we believe, is a very distinctive efficacy profile and a distinctive safety profile. And it met the p-value that was pre-specified at the 12-month mark. And we showed positive results with a very impressive p-value at the 18-month mark. So we're currently going to the final stage of the phase 3 program with a trial that we call GATHER2 that's recruiting. And we're hoping that this will have a major impact in treating patients with geographic atrophy.
Fascinating. So a second phase 3 study, and we'll talk a little bit more about that GATHER2 study here in just a bit. Tell us, Pravin, about the drug.
So the drug itself is a small molecule. It's injected in the eye as a lot of our drugs are. What we've done is to go ahead and use it on a monthly basis in the GATHER1 trial. And what we're able to show, and maybe what I can talk to you a little bit about, is the efficacy profile and the safety profile that we believe is distinctive. The efficacy profile is such that we're able to show a difference between the drug and the sham with the very first measurement at 6 months. And what we were very excited about is that with each sequential injection, that delta between the drug and the sham got bigger and bigger and bigger, with the biggest delta being at the end of the study. Now, we tested 2 doses, the 2 milligram dose, which is the one that we plan to forward, as well as the 4 milligram dose. And we calculated it in 2 different ways. One is using the square root transformation, and the other is using the non-square root transformation. And again, what we're very encouraged with is that regardless of whether we looked at the 2 milligram dose or the 4 milligram dose, regardless of whether we looked at it with the square root transformation or the non-square root transformation, the consistency of that efficacy profile remained, which is again an early separation at month 6, and then a increasing delta with each sequential injection, with the biggest delta being at the end of the study. So we are very confident in the robustness of the efficacy profile and of our data. And as far as the safety is concerned, this drug has been used in multiple different studies. The safety profile has been excellent. There were no drug-related adverse events. The conversion to neovascularization was the lowest that we've seen in class to date. And we believe that there's good science behind it. So we're very excited with the unique efficacy as well as safety profile.
Pravin, you mentioned that growing delta. Why is that so important?
Well, it's important because we've never seen it before, and we believe, again, for the reasons that I mentioned, that it's absolutely real. But think about being able to tell your patient that you expect, if they go along with the GATHER1 study, to be able to see a separation with the first measurement, and certainly within 6 months, and with every single injection, that difference between treatment and sham may get bigger and bigger. It's a very powerful statement. It's very impactful for the patient, and also because the GATHER2 study, the second part of our phase 3 program, is a 2-year study. So if that efficacy profile holds and that delta gets bigger and bigger, as we've seen, we stopped at 18 months with GATHER1, but at 24 months, we're hoping that that delta will be even bigger.
And have you decided on a dose for the GATHER2 study, or is it going to be the 2 and the 4 milligram?
So we decided to go with the 2 milligram dose only versus sham. We had originally, we have looked at the 1 milligram dose, the 2 milligram dose, and the 4 milligram dose. We knew that the 4 milligram dose was not going to be commercially viable because the 4 milligram dose involved 2 injections of the 2 milligram dose due to viscosity issues. However, we wanted to see if we had reached the upper limit of our dose efficacy. And we found exactly what we'd hoped to find, which is that there was a modest response with the 1 milligram dose. The efficacy profile with the 4 milligram dose and the 2 milligram dose weren't that different. But with the 2 milligram dose, the safety profile was a lot better. And again, it was commercially viable. So for that reason, we decided to go with the 2 milligram dose, which seems to be the perfect sweet spot.
John, can I ask Pravin a question as well about this? Pravin, you mentioned the importance of the fact that you look specifically at extrafoveal or non-foveal, non-involving lesions. Did you look at the progression with respect to directionality and whether there was slower progression in one direction, others, in particular slower progression towards the fovea, since obviously that's what we'd like to protect the most for these patients?
So Vas, you more than anybody else and your colleagues have done the most amount of work in terms of directionality of movement, and I think it's been well characterized that the movement of these lesions, for whatever reason it may be, going back to the days when John and Shirley Sarks were photographing this, years ago in Australia, tends to be fairly similar, which is a circumferential movement that's fairly rapid that hits the fovea at the end, kind of slows down. So the answer to your question is we are looking at that right now. In fact, we are looking at that with you and your colleagues in the CAM group, which we think is extraordinarily important for understanding this disease. There's lots of data that we have with the GATHER1 study, and we're looking at that right now. But we specifically picked patients with extrafoveal geographic atrophy because we felt that was a higher bar to test the drug with. If we're able to slow down the disease in the fastest growing geographic atrophy, we felt that the drug would have met a higher bar of scrutiny. We also wanted to preserve the fovea, and we thought that was very important. So it gave us another parameter and another functional endpoint, which is preservation of the fovea, which we wouldn't have if we employed patients who had foveal involvement. So for those reasons, we looked at that, but there's a lot of work to be done with the GATHER1 data. You're involved, your colleagues are involved with that post-hoc analyses, and we'll have a lot more data to report.
Pravin, that's really exciting data, and we'll dive a little bit more into some specific questions about it here in just a bit, but I want to move on to Vas. Vas, you presented your research related to geographic atrophy, and your title of your talk was The Impact of Pegcetacoplan on Progression of Nascent Atrophy in AMD. Tell us a little bit about your study, Vas.
Yeah, thanks very much, John. So yeah, I was able to present some work we did on a post hoc analysis of the Philly trial, which is obviously was a phase 2 trial of pegcetacoplan or APL2, which demonstrated a reduction in the growth rate of GA lesions through the 12-month primary endpoint when the patients were being treated either monthly or every other month. And then that separation was maintained even in the next 6-month phase when the patients came off of the drug. But our focus in this post hoc analysis was really on earlier endpoints, and kind of the rationale for this was that once you have atrophy, that's obviously loss of function, an absolute scotoma in those areas, and so ideally we'd like to be able to intervene earlier in the disease process. In fact, that desire to be able to intervene earlier was the entire basis for establishing the CAM group, which is a classification of AMD or atrophy meetings group. And it was a consensus group to try to figure out how can we get these earlier endpoints. And it was decided that to do that, we really needed to go to OCT as opposed to autofluorescence and color photographs, because we could actually see the layers of the retina and the RP being involved by the disease process. So we're able to define these entities: complete RP and outer retinal atrophy, which kind of corresponds to GA, but also define an earlier endpoint, if you will, an incomplete RP and outer retinal atrophy, which is kind of nascent GA. It's kind of like, the photoreceptors are a little bit affected, the RPE is a bit disturbed, but they're not absent, is probably the easiest way to think about those things. And so the Philly study data set presented a wonderful opportunity to evaluate whether a drug could potentially impact the progression, because obviously the GA doesn't develop overnight, it comes from someplace. And so we wanted to see whether we can interfere with that progression process. And so what we did was we, in the reading center, we took these GA lesions, and then we said, let's look beyond the GA border. So we went at least 500 microns beyond the GA border, and we tried to identify these areas of nascent geographic atrophy or iRORA, and then we looked to follow them over time during the course of the study to see what the progression rate looked like. And we know that, from previous natural history work, that 90% of them might progress to atrophy over a 24-month period. So we expected that we would see some progression events. And in fact, we were able to do this. We restricted the analysis, pre-specified, to the subset of the monthly treated patients who actually received all 12 monthly injections and who didn't develop exudation. So that was a subset. It was only 41 of the patients, but again, pre-specified, and all of the sham group that also met those same criteria. And fundamentally what we observed, the bottom line was that there was a considerably lower rate, a statistically significantly lower rate of progression from iRORA or nascent GA to GA or CRORA in the pegcetacoplan monthly group compared to sham. In fact, it was a 39% reduction over that 12-month period. And that was seen whether you looked at it on a per eye basis, like if any of the lesions converted in the eye, or on a per lesion basis, because obviously the eyes could have more than one lesion. And we also looked at the conversion from drusen to atrophy as well. This obviously, there's not a lot of conversion events in 12 months, and none of those were statistically significant, but there also appeared to be fewer conversions amongst just going from large drusen to atrophy over 12 months in the pegcetacoplan monthly arm. So it looks promising, at least I think, if nothing else. I mean, this is obviously a post hoc analysis, so it's more of proof of concept of the idea that maybe we could intervene earlier in these patients. And so hopefully it'll create a pathway towards the design of early intervention trials.
Hey, John, this is Pravin. If I can ask a question to Vas. Vas, that the study you did was fantastic and extraordinarily impactful, I think, for all of us in the geographic atrophy field. But I do want to ask you two questions. One is, if you were going to look at something you define as nascent geographic atrophy, and you had the choice now of designing a trial today, what are the features you would look at? Is it just iRORA and CRORA, or are there other features you would look at? And if so, what features would they be? That's my first question. And then my second question is, do you think there's a possibility of ultimately having this as a trial endpoint that the FDA would approve? And how would that look for trials?
Yeah, that's a great question, Praveen. I think that I think it's got great promise as a potential endpoint because I think we've got data that even in areas of Aurora, there's functional disruption there, that you may have a relative as opposed to an absolute scotoma as you might expect in an area of GA. And we know that from a regulator perspective, preventing photoreceptor loss would be acceptable. And that's the nice thing about going to OCT and the fact that these are OCT definitions, because some of the differences between iRORA and cRORA is the extent of photoreceptor loss, yeah, even we see, or RPE loss. And so I think that to me is very promising in terms of using this in earlier endpoint. I think the kind of work that is still in progress that we need more of is to really understand the variability of the event rates. We have some information now on the frequency of progression from iRORA to cRORA, but we'd like to have larger data sets because I think when you're doing a clinical trial, you want to be very confident that your study is powered adequately to demonstrate a benefit. But I think those are the key things. I think we did identify, you very nicely pointed out, Pravin, the importance of whether the fovea is involved or not. And lesions that don't involve the fovea tend to progress faster. And we found the same thing in terms of risk factors for progression. IRORA that's not foveal will tend to progress faster. And so that's very important as well in terms of modeling and designing a trial. Also, there are other features that I use in my clinical practice every day. When I look at AMD patients, these so-called hyperreflective foci, which Christine Curcio has shown is evidence of RP migration into the retina. We often teach our residents, we say that the RP cells are so unhappy, they left the monolayer to seek more greener pastures in the retina, and that's why it's such a bad sign. And eyes like that, they tend to progress faster. And so I think these additional biomarkers for progression are going to be helpful for us in identifying the patients who are going to benefit the most.
Vas, tell us a little bit about pegcetacoplan. What is pegcetacoplan? How does it work?
It is a bicyclic peptide. It's a very small molecule. It's pegylated, so it's able to be maintained in the eye. But basically, it sterically binds to C3, and because in the complement cascade, C3 has to be broken down into C3a and C3b, with C3b being the key to sort of continuing down the complement pathway. But because it stops that cleavage, essentially, it prevents all of the downstream components from even getting to C5. And the whole idea behind going after C3 is that you also prevent not only C3b and the rest of the complement cascade from going forward. You also prevent the creation of C3a, and C3a has been linked to inflammation. So there's some rationale that it could be important. But of course, we'll have to see what the pivotal trials show to see if there is a specific advantage to that. But certainly that's a theoretical advantage in terms of thinking about inhibiting at the C3 level.
Fantastic. You guys both did an incredible job breaking down the complex data of your presentations into really understandable nuggets. We're going to take a break. And when we come back, we'll talk about what this could mean for our patients and our practices. Welcome back to New Retina Radio's coverage of the Angiogenesis 2021 meeting. I'm John Kitchens here with Pravin Dugel and Vas Sadda. And we just heard from both of them about their presentations at Angiogenesis 2021, which offer some really promising treatments for geographic atrophy. We're still a few years away from the type of phase 3 study results that could lead to regulatory approval of these drugs. But I'd like to talk to you about the bigger picture of this. And a question for both of you, and I'll start with Pravin. Pravin, complement, something that is maybe difficult for us to get our heads around. Is complement the VEGF of dry AMD?
Well, John, I don't know if it is. It's too early to tell. And the thing that we have in neovascular AMD is that we've got a great biomarker, which is the OCT, which happens to be perfect for measuring anti-VEGF. It doesn't mean that there aren't other things that are involved. There almost certainly are. But in geographic atrophy or macular or dry macular degeneration, we have an objective measurement for geographic atrophy. And as Vas talked about, he and his group are pioneering other forms of measurement for earlier types of geographic or earlier types of macular degeneration before geographic atrophy actually occurs, I think there's a really good chance that there are other factors other than complement, but complement certainly seems to be leading the way. The way that I think about macular degeneration is something that I know Vas has pioneered and talked about a lot, and a lot of his colleagues have, which is that it essentially is a prolonged wound healing process. You know, we used to think of macular degeneration as being a fork in the road, sort of binary, either you get dry or you get wet. And I think of it as a singular highway that leads to geographic atrophy. And it's a slow, chronic inflammatory process that's part of the wound healing process. And like in any wound healing process, there's an interplay between inflammation and angiogenesis. And we know that because if we cut our skin, there's going to be dilation of vessels, there's going to be angiogenesis to allow those histocytes and so forth to get there. So when that interplay causes a misbalance and there's more angiogenesis, then you get a detour in that highway. And the detour is what we know as neovascular macular degeneration. And as good as the anti-VEGFs are, what they do is they put you from the detour back into the highway. And how do we know that? We know that because as good as the anti-VEGFs are, when a patient is diagnosed, they still have 15 to 20 years to live with neovascular macular degeneration. And I don't know if a single study that goes beyond 4 or 5 years that shows anything other than those patients getting worse, not by rebleeding. And actually rebleeding, as you know, is quite uncommon, but because of atrophy. And if you think of them going back on the highway to atrophy, it makes sense. So it makes sense to have complement involved, but you can also imagine the impact of a drug that actually can slow down this highway. It's not just for geographic atrophy, but it may be for neovascular AMD, and it may be for earlier forms of macular degeneration. I think there'll be other pathways involved as well, but I think complement would be dominant in that.
Great answer, Pravin. Vas, I'll throw it to you, but I'll ask you this a little bit differently. Pravin mentioned angiogenesis as a part of this. We know that in these trials, both the Philly study and the GATHER1 study, we saw an increased risk of choroidal neovascularization with these treatments. Is there a good rationale or explanation for that? And is that something we're going to need to be worried about going forward?
Well, I think the exact explanation, I don't think that is clear necessarily, John, but I do think that one of the things that we recognize now, and I think it was always apparent, but our imaging tools are so much better, is that patients often can develop neovascularization in the absence of exudation. And I think many of these patients with geographic atrophy, they can have that finding. And sometimes it never becomes exudative, and sometimes and maybe it never becomes exudative because eventually the RPE cells die and there's no further VEGF production to sustain the neovascularization. That could be one explanation that we don't see it when we see relentless progression of GA. And now when you think about agents that potentially could inhibit that, that may give an opportunity for these non-exudative lesions to convert. I mean, it's obviously possible that there's some other direct mechanism, but it could be simply an unmasking of a process that occurs, we know, of non-exudative AMD converting to an exudative picture. And I guess my thought about that would be, we have effective treatments for exudation, actually, and they're highly effective. And you talked about, you drew that interesting parallel, John, between anti-VEGF therapy and whether these kind of inhibitors are the new anti-VEGF therapy for dry AMD. And I don't think they are, because I think it's a much harder problem. Sometimes when I see my patients, I tell them, they ask like, well, why don't you have a good treatment for this yet? And I say, well, we'll cure AMD once we cure aging. Is oftentimes what I tell them, because it's a really difficult problem, and that's why even these treatments, as promising as they look in these trials, whether it's GATHER1 or the Philly study, I mean, still patients have progression, and that's because none of us have stopped our bodies from degenerating, and so we oftentimes think about neovascularization now as the body's sort of last ditch effort. In fact, when I see patients, when they ask what happened, why did I develop neovascularization? neovascularization. I tell them, like, it's your body's last ditch effort. It's a good idea, but poorly executed is how I explain it to patients. And so we can make the execution better with our anti-VEGF therapy. So I don't fear the development of exudation in these cases. I think that from a long-term solution to try to prevent atrophy for these patients, the neovascularization may be a good thing. So neovascularization working in tandem with our complement inhibition or other mechanisms to slow down GA may actually prove to be a positive.
Great answer, Voss. And you mentioned iRORA, CRORA. Are these things that we can clinically identify now? Should we be familiarizing ourselves with how to identify nascent GA in the clinic? And will there be algorithms built into our imaging to allow us to visualize these things?
Really great question, John. And I think that, we do need to get, as clinicians, we need to at least get better at identifying atrophy on OCT. So at the very least, I think that's important. I do think it's challenging to make these discriminations between iRORA and CRORA, in part because it's not like one day you have iRORA and the next day you have CRORA. They go through a transition. Anytime you have a disease that's chronic, slowly progressive, like GA, you can imagine that identifying these transitions can prove to be a challenge. The good news is there are many groups, and again, I'm a little biased because it's a research focus area of mine, but we've developed deep learning algorithms that can do this. It can seem to do pretty well at doing this automatically. And obviously they'll only continue to get better with better training. So my expectation is that the first answer to your question is I do believe as clinicians, we need to get better at doing that. Phil Rosenfeld has proposed a simple solution of just getting your en-face OCT and looking for bright patches in the sort of the deeper slabs, which highlight the possibility of early atrophy. That's something probably everyone can do relatively easily. But then for the more sophisticated, fine, granular assessments, I do believe that we will have tools available to us with our imaging devices that'll assist us as clinicians taking care of these patients to identify these processes, which again may be very important to identify if we have effective therapies.
Pravin, you mentioned the Gather-1 study was a phase 3 study, and most phase 3 studies, it seems, are run in tandem with another phase 3 study, but you didn't go that route. Tell me a bit about why.
So, John, that's a great question. The concept of a screening study is well known in medicine, but maybe not as well known in ophthalmology and specifically in retina, which is that you can do a study that initially starts out as a phase 2 study. However, you can go ahead and set standards to allow it to convert to a phase 3 study based on very stringent criteria. So you would have a smaller sample size, but what you would do is to design the study with the proper masking like a phase 3 study. In our case, Gather-1 was quadruple masked. The patient was masked, the investigator was masked, the reading center was masked, and the sponsor was masked with an objective endpoint. And the p-value was set at a very high bar, so a very low p-value of less than 0.0125 that was specified. And the results can be one of three. Either you can miss the whole thing, in which case presumably that'd be the end of the drug. You can show a trend towards success but not quite hit the p-value, in which case you'd go ahead and go the primary route, or you can hit it out of the park and actually hit the p-value, in which case it would count as a phase 3 study. In our case, fortunately, both doses, the 2 milligram dose, which we plan to forward, and the 4 milligram dose met the primary endpoint, and this thus counts as a phase 3 study. Again, this is a very well-known path in medicine. We have just employed it in retina. Obviously, it's one of these things where it's quite risky because you have a very high bar. But the company wanted to find out right away if Zimura was something to be advanced or not. And again, we're very fortunate that both doses, hit it out of the park. Realize also that the primary endpoint was objective. It wasn't visual acuity, and appropriately, it was geographic atrophy, quadruple mask. So the regulatory agencies consider that objective endpoint to have a much higher bar of scrutiny than a subjective endpoint such as visual acuity. But again, this is a well-known path in the rest of medicine. It was simply something that we employed and used in retina with the guidance, by the way, of probably the foremost statistician working with the FDA, and that's Tom Fleming. So we're very happy that both doses hit the primary endpoint.
Absolutely. Let's move on to a little more patient-centric discussion, and that is, Pravin, how do we get our patients buying into monthly injections for the treatment of geographic atrophy?
So that's a great question, John. So let me just address a couple of misconceptions out there. One is that geographic atrophy progresses extremely slowly in a matter of years and so forth. And the other is that patients simply won't come in because they're not bothered. And, ironically, the second thing was exactly what I shouldn't say aren't bothered, but just simply aren't going to come in. And the second part is exactly what people said. For neovascular macular degeneration. Again, I'm certainly old enough to remember that. And, and people would say, well, how many patients with neovascular macular degeneration would you see? And at that time, it was like, well, not a whole bunch, because patients just simply weren't sent because there was not a lot to do. They would stop at the optometrist and the general ophthalmologist because we just simply didn't have any treatment at that time. So here's what I think. First of all, geographic atrophy does not progress over decades and years. And you only have to look at great natural history studies, such as in the lampalizumab program, the proxy studies, that show that geographic atrophy, particularly extrafoveal geographic atrophy, progress in a matter of months. There's a very well standardized progression between 2 and 3 millimeters squared, where there is a progression that patients will notice in a matter of months. The second thing is that these patients, although their visual acuity may be great, are functionally debilitated. You think about visual acuity. I mean, how often in life are we in a position where we're in a dark tunnel with a bright light at the end? Never. Our day-to-day interactions consists of contrast sensitivity and color and so on, and distortion and so forth. We don't measure those things. I guarantee you there are a ton of patients out there. In fact, there are studies to support this, who may have a vision of 20/20 or 20/30, but are visually disabled because they may be accountants that can't read a spreadsheet because there's a scotoma, or a lawyer that can't finish reading a sentence, or an architect that can't see a straight line, or an engineer that can't draw a CAD. So there are lots of patients like that. Now, we don't see that as retina specialists because they stop at the optometrist or the ophthalmologist and they say, look, you've got an aging spot and there's nothing you can do that can be done. But once we have a treatment, those patients, particularly because they're younger and in the workforce, certainly will come in if you can slow down the progression of their visual dysfunction. And that's one of the reasons why we targeted patients with extrafoveal geographic atrophy. And if you want to know the numbers, there's a recent publication in Lancet that predicts that in 2040, there will be 280 million patients with macular degeneration around the world. And of those patients, about 0.3% will involve the fovea, but 10%, almost 10% will be extrafoveal. So there's a tremendous number of those patients. And by the way, there's another fallacy too, that this is a disease of Caucasian, not Northern Europeans. The fastest growing demographic is Asians. It may look a little bit different because there are more males, probably because of smoking, than females, but this is a global, worldwide disease of visual dysfunction. And I truly believe that any drug that slows down the progression of this will be tremendously impactful.
So John, can I add to that? I think what Pravin described is really spot on. I was just going to say, even obviously these patients with non-foveal involved disease, especially if their other eye has already been lost, will be highly motivated for these types of treatments. But I would argue that even patients with foveal involved disease going forward, I think that there's going to be a huge premium on preserving as much retinal real estate as possible. And part of the reason is because we're getting better and better low vision assistive devices featuring augmented reality and other tools which can actually utilize areas of remaining retina better. And so that means the more remaining retina we can maintain for our patients, the better chance they have of having more functional vision, even if it requires some additional assistive tools. So I do believe that even though I think this is a huge challenge to stop something, which, as I sort of alluded to earlier, is partly, there's obviously an aging element here and you can't stop completely the process probably. I think that any gain we can get will be important and of visual significance for our patients.
I think you're spot on, Vas. I mean, even if they are involved in their 2060 or 2070, to see these people go to 2200 or 2400 is heartbreaking. And it just happens right in front of you. So for the last question, I thank you both for joining us fantastic guests. I think we've all learned so much more about geographic atrophy and potential therapies for geographic atrophy. Vas, I'll start with you. Within the next 3 years, will we have a treatment for geographic atrophy?
John, I am very optimistic. I certainly think that, the data for these studies looks promising. And there's a whole host of other treatments that are under development, maybe at earlier phases, targeting different mechanisms. And because there's so much activity in the space, and because some of these studies, as I said, the data looks quite promising, I feel optimistic that we will have something. It may not be the home run solution, but it's going to make a difference, I think, for patients. So yeah, I do believe so.
And Pravin, same question for you. Within the next 3 years, are we going to have something?
Well, so John, obviously I've drunk the Kool-Aid. Absolutely. I mean, I don't think I'm totally of the belief that we will. I'm very encouraged that there's so many great companies in the complement field. I want all of them to succeed because it validates the target. But I don't think that's the end of the story. I think that's just the beginning of the story. I think there'll be a lot of other mechanisms that we'll explore. As Vas correctly pointed out, this is going to be a complicated disease, but this will be the beginning of the story. And I believe that it won't be a single drug. It won't be a single mechanism of action. It'll be a combination, and it'll be extremely complex, but extremely interesting, because there'll be some that'll be gene agnostic. There'll be some that'll be gene specific. We'll have injectables, we'll have gene therapy, we'll have different kinds of proteins. So I think this is an incredibly important space that will potentially be the most impactful thing that we do in ophthalmology.
Absolutely. Well, listen, thanks to you both, and congratulations on your great presentations. That's it for this episode of New Retina Radio's coverage of the 2021 Angiogenesis meeting. Remember to keep an eye out for our other episodes from Angiogenesis, which should be in your feed shortly.